A very good evening to one and all. Wishing you all a happy and prosperous New Year 2024 in advance. I heartily welcome all the members of ACP, API, Karnataka and World Medical Academy and other members of various organizations who have joined virtually from all over the country to attend this program on COVID-19 update. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus RGHS, KBN University, Gulbarga, Dr. Muruganathan, past Governor, ACP India Chapter and past Dean and President API, who will be joining shortly. I also welcome our own committee members, our patron API Karnataka, Dr. Maya Sir, Dr. Murali Mohan, Chairman API Karnataka, Dr. Vishwanath Secretary, Dr. Ravi Kirti, Central API Member. I welcome our today's chief guest, Dr. Girish Mathur, President National API from Kota, a dynamic leader of API with great visionary, taking API to a great heights both nationally and internationally. I welcome our today's speaker, Dr. Raman Gangakherkar Sir, Padma Shri Awardee, former head ICMR Delhi, who was involved in guiding the Indian government in COVID-19 epidemics in earlier waves also. A great scientist, researcher, earlier heading the Department of Virology in Pune, a great academician who never said no to any of our earlier invite, that speaks his commitment and dedication and passion for teaching and updating all of us. I also welcome our today's moderator, our own faculty, Dr. Ravindra Mehta, a dynamic personality in the field of pulmonary and critical care from Apollo Hospital, Bangalore, and also a well-known interventional pulmonologist in the country with many publications, both nationally and internationally. I also welcome our panelist, Dr. Ishwar Gilada, President of AIDS Society of India from Mumbai, a great name in the field of HIV medicine in the country, an international name in the field of medicine with many publications to his credit. I also welcome our other panelist, Dr. Suresh Kumar, Chief of Infectious Diseases from Apollo Hospitals, Chennai, who is a pioneer in infectious disease in the country with many publications to his credit. Lastly, I welcome our own colleague panelist, Dr. N.K. Singh from Dhanbad, Jharkhand, who is running CME India, from India platform by educating and sharing clinical knowledge to physicians all over the country by discussing clinical cases, helping the practitioners. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते शुभं कुरुत्वम्.
We are virtually honoring all our faculty also. Now I request Dr. P.S. Shankar Sir to address the gathering.
Dr. Mathur, Dr. Gangakherkar, Dr. Mehta, Dr. Gilada, Dr. Suresh Kumar, Dr. Singh, Dr. Muruganathan, Dr. Murali Mohan, Dr. Maya, Vishwanath, and Ravi Kirti, Dr. Sangram, and colleagues. We have assembled today for COVID-19 update and to understand the JN1 variant. We have amidst us Dr. Gangakherkar, the doyen in the field, We have also honored Doyen and my good friend Dr. Gilada for this program. Dr. Mathur is attending as the chief guest, and other speakers have come from different parts of the country. I welcome them and our API team and Dr. Muruganathan. SARS-CoV-2 continues to evolve since its appearance. While the world was in the grip of COVID-19 pandemic in 2020, new variants of the virus began to appear late in 2020. The Alpha variant B1117 was noted in southern England, and it spread more easily and affected younger population. Beta variant B1351 appeared in southern Africa, and it had the potential to reinfect the persons who had recovered from earlier strains of the virus. The mutation being on the spike protein helped the virus to infect its host easily. It had a capability of spreading more easily. In January 2021, Gamma variant P1 was noted in US in a group of travelers from Brazil. They spread more easily than original virus and were more contagious than earlier strains of the virus. They were capable of evading the antibodies produced by an earlier infection or a vaccine. They exhibited marked transmissibility with a greater affinity to human receptors. The variants became more and more contagious with each mutation. The Delta variant B617 was detected in India in December 2020. It was a highly contagious strain and spread more easily than other variants. The emergence of this variant was linked to a greater surge of infection in India in April 2021 as second wave. This highly contagious variant is found in 43 countries. More young people got infected from this strain, and it was more transmissible than other COVID-19 variants. There was also Delta Plus variant first recognized in Uttar Pradesh, which later was noted in other parts of the country. Since February 2022, Omicron stands as the most distinctive variant of Delta lineage. It has undergone genetic and antigenic evolution, resulting in a growing array of sublineages. The pandemic of COVID-19, which plagued mankind, has receded, but the coronavirus has not disappeared. COVID-19 is now an established and ongoing health issue. The new EG5, nicknamed Eris strain, a subvariant descendant of Omicron, made its spread early this year. Another new variant of Omicron, BA286, nicknamed Pirola was noted in July this year, and by August it made a global spread. BA286 has evolved in a year and has mutations. One of them is JN1. This has entered our country through Tamil Nadu and Kerala and is making much noise in many states. JN1 variant assumes significance owing to its ability for growth advantage. It has a high risk owing to a faster replication and higher transmission and immune escape. The symptoms are less severe. Due to its rapidly increasing spread, WHO has classified JN1 as a separate variant of interest from the parent lineage BA286. This virus was first detected in Luxembourg on 25th August 2023. JN1 has additional L455S mutation in the spike protein, which enables its rapid transmission. Due to presence of hybrid immunity following repeated natural exposures and multiple doses of vaccine, virulent spread of the virus is unlikely. The virus is likely to maintain a low level of endemicity. The virus has low potential to cause serious illness in immunocompetent individuals. The same pandemic protocols that were carried out to prevent the spread of the disease will be effective. Masking, social distancing, hand hygiene testing, avoiding sick people are crucial in its control. There is no need to be panicked, but be vigilant has to be our motto to fight the new variant of coronavirus. WHO has urged to strengthen surveillance in view of the increased number of respiratory disease, including JN1 virus, and to take protective measures since COVID virus continues to evolve, change, and circulate in all countries. We are eager to hear from the Doyen Dr. Ganga Kedkar on JN1 and the panel discussion on COVID-19 from the experts. I am happy to associate with the inauguration and wish the program all success. Thank you.
Thank you, sir, for your kind words of wisdom and sparing your valuable time. Now I request our chairman, Dr. Murali Mohan, to address the gathering.
First of all, it's such a pleasure to be here and to again have the opportunity to hear Dr. Ganga Kedkar, who is an absolute fountain of knowledge in the area of infectious disease in general and in COVID-19 in particular. We've heard him in the past and always learned so much from him. So welcome, Professor Ganga Kedkar. We have a wonderful panel today. I will not go into more details. Welcome to Dr. Girish Mathur, of course, our very senior fountain of knowledge again, Dr. P.S. Shankar, Dr. Gilada, who made such a name when the AIDS pandemic started with his service to this then neglected community. And of course, my dear friend, Dr. Ravindra Mehta, who will be moderating today's session. Dr. Sangram Biradar, thank you for inviting me to be part of this group. And Dr. N.K. Singh, again, another person who educates us every day. Without further ado, I'm going to hand it back to our organizer for the day, Dr. Sangram Biradar, to take the proceedings further. It's such a pleasure to be here, and I look forward to hearing the panel discussion also. Thank you, sir.
Thank you, sir. Thank you. Now I request our today's chief guest, Dr. Girish Mathur, President API, for your inaugural address.
Good evening, friends. Dr. Maya, Dr. P.A. Shankar. I think Dr. Shankar discussed almost everything, and he hardly left anything for speakers to discuss today. Dr. Murunathan, Dr. Murali Mohan, Chairman, API Karnataka, Dr. Vishwanath, Secretary, API Karnataka, Dr. Sangram Biradar, Member, Governing Body, and the very distinguished speakers and panelists of today's discussion, Dr. Raman Ganga Kedkar, who is an institution in himself, Dr. Ravindra Mehta, Chief Pulmonologist, Apollo Hospital, Bangalore, Dr. Ishwar Gilada, President, AIDS Society of India, Dr. Suresh Kumar, Infectious Disease Specialist, Chennai, Dr. N.K. Singh, a very highly reputed physician from Dhanbad, who is doing a great work and enriching academic excellence of physicians across the country. It's my immense pleasure to be here at this COVID-19 update organized by API and ICP Karnataka and Hall Medical Academy. COVID-19 is again making headlines with the WHO classifying JN1 variant as variant of interest. This strain is spreading rapidly, leading to an uprise in cases globally, including in India. However, with available evidence, it appears that public health risk appears to be low at the global level, but we need to be vigilant and watchful. To discuss the whole gamut of the problem, we have a highly accomplished panel with us who will clear all doubts and concerns that we have in our mind. I wish my best wishes for the success of the program. Thank you.
Thank you, sir, for sparing your valuable time. Thank you. Now I request our chief moderator, Dr. Ravindra Mehta, to take over for further proceedings for the scientific session. Since Dr. Muruganathan will be joining later, we will hear from him in the middle of the talk. Over to Dr. Ravindra Mehta.
Yes, so good evening, everybody. And on this New Year's Eve, or a little before New Year's Eve, as we're winding up the year, we wind up having COVID reminding us that it exists and how it exists. In fact, it's very intriguing when you look at the metaphysical or the philosophical part of it. A virus which is not going away, a virus which mutates, a virus which has got more alphabets than we can probably come up with in the long run, a virus which is so smart that it is figuring out its survival, and a virus which certainly seems to be ahead of the human race in its ability to spread and sustain itself in a short span of time. With that, we are, of course, trying to get interesting clinical insights, updates, as the worldwide community tries to put its information. And at the same time, we see a definite lag where we see that the initial push, the enthusiasm of trying to tackle this is now left with just a small semblance of what it is. But at the end of the day, the ball is in our court. We as practitioners have to know more, be the speakers of the change, be the guiding voices when we ourselves, frankly, don't know enough, and take all available information and put it into capsules, which are both illuminating, guiding, and at the same time not prohibitively scary. We cannot ignore the social economic scene. This is an India which is economically strong, mobile, traveling, open, and totally seems to be unaware or uninterested in the fact that COVID needs its attention from time to time. At the same time, the push of the international community in trying to have medications, vaccination, and so many other entities which became synonymous with COVID care has waned. So we're looking at a paradox where this thing never goes away. It rises like the phoenix in some form or the other. Is it possible for the global community with all its priorities to rise up to the occasion? What is the latest and greatest in this? What do we do, and how do we leave this audience with some take-home lessons in the big picture of what's going on? So with this particular theme, I thank Dr. Sangram Biradar, all the amazing August luminaries. I think it's a good fortune to see you online at least, because I doubt we'll see you on site in this fashion, to come together in a topic, this 5-letter word, which has been around so long and will stay around long enough to generate interest. So with this, I hand over the virtual stage to Dr. Raman Gangakhedkar to take his talk ahead, and then we'll go on to the next part of the proceeding. Over to you, sir.
1 second, sir. Yes.
Yes, sir, it is visible.
Yeah. Now, am I audible?
Yes, sir, yes, sir.
Yes.
Now, what we are going to do is actually try and see how the science has moved fast enough in view of this particular challenge, and try and understand this particular variant that has emerged. What we know and perhaps what we don't know is going to be far more than one should actually reflect upon. Now, if you recall, WHO declared the public health emergency as over sometime on 19th August 2023. Now, what was its impact? Everyone dreamt of a revenge holiday after 3 years. But then there is some issue. Suddenly, Kerala started reporting that a new variant has come to us, JN.1. No, it was a single case that they reported in the beginning. But once they reported, it became apparent that this is becoming more common elsewhere. This was mainly because Kerala tends to have one of the best public health systems. They continue to follow whatever surveillance requirements that are to be implemented across in their state. So there is no complacency in that particular state to my mind. Now, when we think of these numbers, even today, majority of us will feel that they sound to be small, no? They are into 2 to 3 digits. 3 digits only come when we think in terms of a national figure. But should I be worrying so much about it? Some of us will feel, no, yes, we should worry. Some will say, no, we don't need to worry. But we need to remember that these are absolute numbers. We cannot factor those who were not tested ever, no? In this particular state when they were symptomatic, when they are sick per se. Let us try and understand those issues as we go ahead. You will also need to take one fact into one's own mind that the media may sensationalize these numbers. No? They might say that from 600 today it has become 1200. No, we will have to counter those issues mainly because we haven't refined our stance. No, it is not absolute numbers that we are worried about. number of infections do not count when the virus has evolved so much and it is becoming mild and milder. What is most important is we need to have a good hospitalization surveillance. We need to have good death surveillance due to COVID. Only then we will be able to react to these numbers really well. But we also need to recognize that this virus does not have only health related impact. It also has non-health impact. It can ruin the economy if the panic spreads in and people start voluntarily staying at home. We need to avoid that part also, because today we are into a different setting. It's not the same COVID that we used to talk in the past. We have good treatment, we have good vaccines which are available. Now, why should we worry? If we worry, we have to worry in terms of, will the people respond to our messages of adherence to COVID appropriate behavior? And how we promote that is going to remain as a major challenge. Now, when we think about the global spread of this JN1 in November 2023, you find that in France it went from 11% to 45%. In USA, it went from 2% to 20%. If you look at Singapore, it is 1.4% to 72.7%. This is a story up to November 2023. Canada, it has gone from 1% to 10%. These are proportionate infections of JN.1 among all COVID cases. When it comes to UK, it is from 1.8% to 21% almost in November. If you look at Sweden, it has moved from 2% to 22.9%. Can I ever say what is happening in my country? It is tough. Because as I said, our health seeking behavior tends to be low, treatment seeking behavior is low, and then our sampling frame for understanding the same continues to be one which has too many weaknesses. We should hope to try and advocate for the right kind of surveillance where meaningful data can be drawn, and we should be able to generalize that data. Now, if you want to know more about JN.1, we should also try to look at the phylogenetics. Now, from where has JN1 come? Now, if you look at that arrow, you will find the arrow points to JN1 as you see in the phylogenetic tree. Now, if you actually look at, this is actually a descendant from BA.2, one of those infections that occurred in India as commonly, whether it was BA.2 and BA.5 was also one which was predominating during the Omicron wave. Now, of those BA.2 lineage, you suddenly find that you have BA 2.86, and then it has given rise to a grandchild, which is JN.1. Now, these two streams that you are seeing of BA.2 and XBB, the father is BA.2. No, but he has conferred genetic gift to the progeny so much that they are favoring survival of that particular branch better compared to BA.1, which was another strain that was seen during Omicron wave at that juncture, and XBB related variants and 2.86 related variant at JN1 are the ones which are causing major havoc all across. All of us know that SARS-CoV-2 is coexisting with us. And it is looking for an opportunity, how to survive, how do I mutate, and I need to survive. The father of this particular JN.1 is BA.2.86. And this particular BA.2.86 is actually far different from its own father by 30 different sites compared to his father's genetic characteristic per se. But one thing which we must remember, that 2.86 did not bother us much. We did not care about that infection, despite the fact that it had a propensity to spread and perhaps even become a predominant kind of a strain. We will try and see why. No? If you think in terms of why is this BAP was benign and the sun is a Savai? No? It is just one single mutation in JN.1 in the spike protein, which is L455. Now, if you read literature, you will find people will keep on writing L455S, but that S stands for spike protein. That we must remember. And this small point mutation, it confers a new kind of ability to go for immune evasion for this JN.1. If you actually look at what is happening in the evolution of this virus, you will find I'm using a wrong word, which has become politically incorrect word otherwise. The mutation site of 455 is a Panvati for human beings. If you look at that small figure that is seen in this particular slide, you will find most of the mutations, when they are occurring around 455, they are creating problems across. But you have now the worst fit kind of a variant that has emerged, that is JN.1, which has L455 mutation at that particular site, and therefore it is causing major problems. So what is that data saying to us? We need to understand what is right and what is wrong. So far, this is a new infection. So essentially what will happen? We don't have sufficient data. There will be conflicting data that tends to emerge. And because we never thought JN.1 could affect us. If you look at the study from Belgium, which is yet to be published, it says that there is no difference in odds of hospitalization with JN.1. The odds are 1.15, but at the same time, that is not statistically significant. If you look at preliminary data from Singapore, which recently faced increase in JN.1 cases per se, you find their data tends to point that there is a lower risk of hospitalization and severity. Now, none of these data can actually be utilized for interpretation so easily, because we have very effective drugs which are available. Unless you factor those drugs, you will never be able to interpret that data, and therefore limitation of the data is a major issue that we have to keep at the back of mind. From where does this data come, which is more robust? Perhaps USA continue to have good genomic surveillance. They have a good hospitalization surveillance as well as mortality surveillance in place. Now, if you look at the COVID, what is it that they are reporting? That there has been increasing trend in percent test positivity. That is TPR, the way we used to say. It has just marginally increased by 0.7%. But if you look at the emergency visits that people tend to make, in the last week, they have increased to about 12%, which is a sizable number to my mind, though it is not significant, and there is an increasing trend. If you look at hospital admissions, in the last week, you will find that about 17% of increase has been noted in hospital admission. We will try to understand why this is happening subsequently. If you look at the COVID deaths, there is a increase of about 10% in the most recent weeks. Now, can we attribute most of it to JN.1, or can we attribute to something else? Is something which we will try and understand. If you look at JN.1 in USA, you will find the violet bar that you are seeing in that particular picture. It actually has started rising dramatically sometime from November. And today, if you look at JN.1, which is represented as the violet figure, you will find currently you have up to 44% of infected individuals who perhaps have infection from JN.1, right? If you look at the confidence limits, they have tested sufficiently. You find perhaps this figure lies between 39% to 50%, which means the numbers that have been tested for genomic surveillance have been as high. No, so we can rely on this particular data. Now the virus is spreading far more rapidly in US per se. Now, was it reflected in the wastewater surveillance, something which India adopted uh, in our own country as well? No, you look at those red spots. No, there are almost all states of their zone. No, you find that 80 to 100% of those samples that are coming, they are showing presence of COVID virus, whether JN.1 or some other one is something which we would try to look in. But the active sites, hotspots, are far too high if you actually look at the entire map that you are seeing. What is the forecast for them? They have a very well developed health system. If you look at them, they tend to forecast how many people would be hospitalized because of COVID-19. Now, when they look at it, you find data which is contrary to what we would have thought. No, the current trend of daily hospitalization in US lies anywhere between 1,400 to 8,700 patients admitted in USA across. No, now that's also pretty wide. No, we don't know why, but at the same time, you will also find there is they have observed that in one of the regions, the virus perhaps leading to admissions has gone down as such. So there is a contradiction. We see in wastewater, we see in all other data that comes from surveillance. We suddenly find when it comes to hospitalization, we are unable to see that all of them are not getting admitted. But to my mind, if you ask me, it is because they use drugs. It is because they are providing Paxlovid to majority of the people. You will find that they will not get admitted in the hospital despite the fact that otherwise they would have had needed a hospitalization. Now, who is infecting people in USA? The soup, as we say in research, soup is, you put small amount of viruses from some group, small amount of viruses from others. In research, we call that particular mixture as soup. No, it may be different from what we currently, what commonly we tend to refer. You would be surprised to know that there is a big competition. There was a big competition between two variants. One was JN.1, the other was HV.1. If you look at who's predominating now, HV.1 was the most predominant strain until some time, just a month back. Now JN.1 has almost crossed it 2 times, no? In terms of the prevalence at this juncture. So essentially means that JN.1 has a better ability to better transmission efficiency compared to HV.1. Now we need to, they are going, these viruses are taking us to our own philosophy, where we look at ancestry as a typical approach that Indians tend to have. You look at JN.1, you look at HV.1, they belong to Omicron family. If you look at HV.1, which nobody talked about earlier in our parts, the sublineage is from XBB, XBB 1.9.2. Who's the direct descendant? Because now we are seeing the grandchildren, grandchildren who are affecting us for a long period of time, and we are going to see that over a period of time. No, we really don't know when it would end so easily. Now you find that JN.1 actually came as a direct descendant of Pirola, the BA.2.86 virus, Whereas HV1, no, I wish I had kept that slide of phylogeny. It is a direct descendant of EG5. Are they really different when it comes to comparison between descendants? Not significantly different. What was the first time that JN1 was reported? It was in September. Now you have 44% of cases of COVID which are occurring because of JN.1. If you look at HV1, it was reported sometime back, in July, and now you have close to about 22% cases that can be attributed to HV1, which is causing infection in USA. Now, one thing which we have to understand, can we prevent this infection? In US, they have mRNA vaccines. Now, these vaccines are having bivalent preparations made for boosters per se. What is it that they have? Now, the bivalent one tends also to have Omicron, and which is the variant that they are using? XBB.1.5 variant. Now, some of us will wonder, no, XBB.1 perhaps is more closely related to XBB. But the reality is, there is very little difference between XBB and JN1's father, the 2.86 variant per se. Therefore, these current boosters which are available in US, they continue to be effective. That's something which we have to recognize. But the unfortunate part is our biological interventions are effective. They can be, they need people to accept it. The people across the countries actually do not differ. Now let's try and see what do I mean by that. You find there is a vaccine hesitancy and COVID fatigue that is catching up as of now. Now, if you actually look at how US has performed, you find those who have taken at least one dose, you will find the numbers are extremely good. When you reflect into the past, they are around 85 to 90% of the people in different age groups, they took at least one dose. When it comes to the primary series, that is 2 dosages per se, you see a drop. Now you are talking in terms of who has taken, you will find they tend to be between 70 to 80%. And the only people where they were perhaps more satisfied is at least they could see those who are above 65, 94% of the population actually received both the dosages of vaccine. But now comes the most dramatic part. What proportion of the population has received the boosters? Now, there we tend to have a major issue because if you look at less than 60 group, it is only 20% of the population. But there is some hope, because at least those who are above 65 years of age, the proportion goes to 43%. But is that sufficient enough to prevent infection or even hospitalization among them? It tends to leave lot of room for implementation of program. Now, one question that will come to our mind, what was happening in India as such? Were we different? Now, if you look at the INSACOG data, from December 22 to April 23, you will find that the virus was very much there. You also find that there were different strains which were predominant. And what was the variant that was predominant then? It was XBB. Until the time it was April 2023. It is also important for us to recognize we tend to speak a lot with assumptions. No, we tend to say the comorbidities make a difference. If you look at the data that tends to emerge from India, you will find among the people who died, when you dissect them by comorbidities, you suddenly come to know that people who have comorbidities are likely to actually have higher risk of death, as evident in the slide as you see. Additionally, if you actually look at these subclasses in that particular paper, you will find age is an important issue. There were, of those who died, let's say 62 people who died, 6 out of 62, who were actually, I'm sorry, I made a mistake in saying, there were 62 people who were more than 60 years of age, 6 of them died. That proportion, if you try to compare with those who were less than 60, you had a number of 324, only 2 people died. So it essentially means when we talk of an issue that those who are at risk, those who are belonging to higher age groups and having chronic morbidity need definitely try to protect themselves, whether through vaccine or a better treatment seeking behavior. The bigger worry, we had a very good surveillance mechanism as INSACOG. Now, nobody should misunderstand my statements. But when the government came out with a statement on JN.1, look at this statement that comes. I am still a hardcore ICMR person, but look at those dates. No, the first case of which was RT-PCR positive, which was JN1, was in November 18. When did we confirm that? December 8th. And then when did we start mock drills? We started on December 18th. We need to reflect hard. India is poised to become a developed country. We need to hasten up these processes to ensure that we don't lose on time and try to fight out or nip the bud in time. That is perhaps an approach that we need to have in systems. What is it that we are seeing currently? Now, if you look at what is happening across in India, ICMR has a VRDL network where we tend to have those ILI and SARI cases, which are actually classified with different infectious agents so that we know those proportions per se. What is it that we are still facing as the data tends to show? Even now, RSV is more common in children and influenza in adults, which essentially means JN.1 has recently come in India. Now, our task has to be that it doesn't spread as rapidly and cause a problem to the health system. We need to adopt right kind of approaches. Now, one of the things which I feel is important is if you look at those viruses, and our past VRDL data, these viruses, majority of these viruses tend to take holidays post-Christmas in New Year, which is unlike us. We tend to take holidays during this Christmas period. You will find the causal proportionate morbidity of any particular viral disease is higher, but it tends to become lower the moment we start a new year per se. But what is most important for us to recognize, there is the difference. The difference comes with SARS-CoV-2. SARS-CoV-2, the proportionate morbidity suddenly starts increasing in the new year, which is a good thing for us in a way if you look at it positively. Any person who comes to you with symptoms which are relatable to Omicron infection, perhaps you will be far more accurate without testing that this person may be having COVID per se, which was not possible in this particular period. It will happen in the next year. And that makes our task little better in advising to others per se. So what does it essentially mean? The SARS-CoV-2, it tends to come in form slowly or it attacks us when we become complacent. Because now we say, अच्छा winter आया है, winter में तो ये बीमारियां रहते हैं. Once winter will be gone, we will be free of these respiratory organisms and we become complacent. But the reality is, it is possible that you will again see a major spike of SARS-CoV-2 sometime in the new year itself, we need to be vigilant. Unfortunately, we have another old enemy from influenza family, which always wants to meet lineages. No? If I, I will try to show the earlier graph, so you will understand. India is in a unique destination theme, no, for viruses. If you look at influenza and the strain that we select for influenza vaccine, we are at the worst possible place per se. Because you must remember, these viruses tend to come from southern hemisphere. The virus is different from northern hemisphere. That virus is also different. Northern hemisphere starts first, southern hemisphere starts later. Unfortunately, they tend to have a destination holiday in India. Now, why this becomes a worry? You know, there you will always find that influenza can also be a complicating factor in handling these respiratory infections. If you recall, in 2018, we suddenly said H3N2 was not part of the influenza vaccine that we were providing. This happens because during the tenure that I had, I tried my best as to how do they model which strain should be a part of influenza vaccine. And the reason was, if my holiday destination is different, if influenza is going to attack at different points in time, there is an outbreak that occurs around July, and there is another outbreak that is occurring right now. Now, how do I fight? Unless my country has an ability to predict those strains correctly, people will continue to have higher morbidity and they could be dying. I went to an extent, I asked WHO, how do we do it? You inform us, you teach our people. WHO seriously said that we constitute an expert group. We don't have that kind of strength. CDC is one which does all these kinds of modeling exercises and they suggest to us. I even talked to Fauci. Fauci had agreed. Unfortunately, my bad luck was that COVID came. I could not do much. But influenza is also going to bother us. Why am I bringing this up? If we will need COVID vaccine for elderly people, we also need to worry which vaccine I have to give for elderly for influenza. Because now is a time where we have to look at immunization among elderly as the right choice. Yearly immunization has to be thought really well. Now, one of the issues that is becoming important now is, will post-COVID syndrome increase with JN.1, which is a highly transmissible strain? Because one of the issues that we know in post-COVID syndrome, the more the number of times that you got COVID, the risk of development of post-COVID keeps on increasing. We also know ACE2 receptor, no, it is present almost everywhere in the body. If you look at our past knowledge, the past knowledge, when we began in 2020, we never thought that SARS-CoV-2 will actually infect most of the organs. We thought it's only lungs. No? Until the time we recognize this post-COVID syndrome. But the unfortunate fact is ACE2 receptors are all over in the body in different organisms. There is a beautiful study that is going on in US, which is called as INSPIRE study. If you look at the kind of syndromes that they are looking at, they have already done about 3 years follow-up of those 5,000 odd patients in every 3-monthly interval. You will find our perception in India is that cardiac events tend to be more common. No, we tend to say myocardial infarct among younger people have increased because of COVID. Now, if you see the first part of, how would I say, the first graphic pattern that you see here, it is actually cardiovascular events. but the rest of the ones still have a higher bar. We are yet to get the final results from this particular study, but they are going to be torchbearers for all healthcare professionals, all those who get infected. What, how should I monitor their health? How should I find out other complications are not likely to happen in my patient post-COVID is something which will be decided through INSPIRE study to my mind. Why is this becoming important? Huh? One of the studies that was very recently done, the first study where they tried to actually compare in USA failing and non-failing hearts. No? This is one study which perhaps we cannot undertake in India. Our ethics committees will not allow any such thing to happen because you require those heart tissues, no, from people who may be going for transplant or those who are dead, after COVID infection. What did they find? That ACE2 receptor is present in the heart and the virus can actually infect the pericytes and therefore they can cause myocardial events. No? And this has become far more important now because the most recent preprint that you will see, what does it say? That most of the people, when it comes to persistent infection with SARS-CoV-2, would have the virus which is replicating in the heart tissue. If that happens, the Japanese people, they have actually tried to warn us, though this is a study which has been done, which is an in vitro kind of a study. What they say is there is a heart failure pandemic, which is actually something that can happen because of COVID. No, so we need to be vigilant. And as I said, the INSPIRE study perhaps is going to throw more, perhaps information. We should make us guarded and ensure that our people do not succumb to these particular complications, and at least we should not be facing heart failure pandemic. How do we handle this particular situation? We should ensure that we should not create panic. Despite the fact that our anxieties of future implications may be high, we cannot speak in public. That's not good. We have to confirm those findings. Now, most of the people will come to you and they will say, I had taken my vaccine earlier, which was based on Wuhan virus. They would also say, I had got an infection, so I have a hybrid immunity. Does that help you? JN.1 has a 2.1-fold decline in neutralizing titers against BA2.86, which was a predominant virus with which we were getting infection in Omicron wave per se, which essentially means that our immunity is waning. The virus has outsmarted our own immune system. So we may have to think in terms of providing right kind of vaccine to people at this juncture. The options that we can offer to people, you can provide an effective mRNA vaccine, the Gemcovac OM, where we have OM stands for Omicron. Currently, we have close to about 10 lakh dosages which are available and they are marketed across in the country. You have Incovac, which was produced by Bharat Biotech, which is a nasal vaccine. We do not know whether use of Incovac is going to ensure that my mucosal immunity would be as good as child's immunity if I take it as adults, and perhaps will help me reducing the incidence of different infections that tend to occur due to COVID. Effective medicines, they are clearly available. You have Paxlovid, which is available in the country, costs around 6,200 rupees or whatever for the entire dose. you have remdesivir, if you can provide both the things, no, you could take Paxlovid as a oral drug and prevent hospitalization, but you will have to monitor for rebound, which tends to occur in a small number of people, sometime around 10 days or so. Best example was Trump at that time when we actually looked at what happened in the past. When it came to remdesivir, today we know that if you give 3 dosages of remdesivir in first 3 days of infection, you are likely to be better off, in terms of the mortality outcomes. Molnupiravir, we must remember it's a drug which is alleged to increase the drug resistance that could occur because it helps the virus to mutate. We do not know, but Paxlovid is available, remdesivir is available. And what is also important is we have to involve all stakeholders. We can never win this war without involving patients. We need to think in terms of adherence to COVID appropriate behavior. How would we actually formulate our strategies to tell them? Are the symptoms different in this particular JN.1? Absolutely not. If you read all, you will remember that all these symptoms were part of Omicron variant. Still, there is a trend, no? Somebody comes with sore throat, congestion or stuffiness and dry cough for a longer period of time, perhaps he is also more likely to have JN.1, which needs to be confirmed through different studies, which we must undertake. Do we need to do contact tracing? One of the difficult problems. The reality is we don't need, because this is highly transmissible virus. We should not spend our manpower, their time unnecessarily in doing contact tracing. Each one of us in our own states, we should speak against the public health department doing contact tracing, which is not required as of now. Should we isolate infected person perhaps for 5 days, if you want, or perhaps if he has fever, if for next 24 hours, if for last 24 hours he doesn't have fever, then perhaps he doesn't need to follow COVID appropriate behavior. But when we talk of such issues of isolation, nobody is going to listen and adhere to our advice. That's a reality check. I really do not know how we can handle that. How should we protect ourselves as a healthcare person? This is another dilemma that all of us will have. Because most of us may have already been infected again and again by this Omicron, and their different family members, even before JN.1. We will need to think over a little better and devise strategies as to how do we protect ourselves. But to my mind, I really do not know one of the worst things that can happen. Worse in the sense that one of the definitive interventions that may happen for healthcare providers is all of us may have to be vaccinated periodically to ensure that we don't acquire different variants per se. Can this variant cause Delta-like wave? One thing which we must remember, the more you will test, the more will be the numbers. But we need to actually look at the practicality now. Should we focus on the younger generation for testing? Yes, you may, but I need to focus more on at-risk individuals, provide them medicines to avoid hospitalization and death, which is an eventual outcome. Now, if we do that, perhaps we will be better off, even in this virus variant, which is spreading rapidly. Do we need to think in terms of something which is beyond genomic survey? Now, this is complete a thought that I had. There are two types of variants. One, which may be that they have a high binding affinity to H2 receptors because of the mutations that are occurring in spike protein. There could be another lot which has low binding affinity and they could be infecting they are less likely to infect the individual per se through the mutation that has occurred. But we must remember, mere genomic surveillance, which is a mutation, which is an outcome of what has happened, we may have to look at binding affinity as an additional test that we should be doing. Those variants which have high binding affinity but are unable to cause immune evasion are most important mutations which we have to keep on watching. We should not be looking at hundreds of variants that you will actually see after genomic surveillance. What we should be actually following is a small proportion where perhaps you see more of a danger in future. That would be one way to go. So we may have to add functional assays to identify what could be potentially the variants of interest in genomic surveillance and try to pick them up early so that our job to actually implement different strategies will become easier. There is no reason to panic. We have both. What is most important is vaccine to reduce hospitalization and the medicines as well, which prevent hospitalization. We have, as healthcare providers, as researchers, we have an internal concern. What would be the impact of this particular infection on different organs after getting that infection? My worry is not about API. My bigger worry is when children get this infection, they are going to live longer. We are still not focusing on children, whether it is going to affect different organisms and different organs and create problems for them subsequently. What is important for us to understand, you may be able to prevent infections among adults if adults cooperate. But when it comes to children, you will find that you will fail most often and rarely win, if at all. Will this cause a tsunami at the gates of heaven again, the way we had seen in Delta? It is up to us to prevent death by using drugs, vaccine, and motivating people, especially at least elderly, where we speak about COVID appropriate behavior. If we would fail due to non-adherence to CAP, what we must remember, we will open up the gateway, the expressway again. I believe we can be successful with the community together. We will block the road and ensure that people don't face the problem at Heaven's Gate ever. Thank you for listening me listening patiently to me. And now you must have noted that I or all of us hardly know anything about JN.1. But it is important, we need to keep vigilance per se. Thank you.
Yeah, Dr. Mehta.
हाँ हो गया सर.
Yeah.
So thank
Can
you
you
so
stop
much.
sharing, sir? Raman, sir.
Yeah,
kindly.
I will.
Dr. Biradar, should I continue?
Yeah, continue. Yeah, over to you, please.
Yeah, so thank you so much, Dr. Raman, for a very comprehensive, panorama-based, knowledge-filled perspective, summarized talk, which puts a lot of the questions into the minds of people, and as you said, creates equal amount of doubts and queries as it attempts to answer. So we have a very august panel with us here. Do I have everybody in the panel with us? Is Dr. Gilada, Dr.
Yeah.
Suresh, Dr.
Yeah,
Singh
Gilada.
there?
Yeah, Gilada
we
is
are
there.
here.
Yeah. So I think we can, hello, sir. We
And
can
Dr. Suresh also is there, Suresh.
take questions from the audience, as I can see it in the chat box as they post at the same time in the next 15 to 20 minutes. Try and also add to Dr. Raman's talk. So let's start with some, we're going to be varying now because like he said, we don't know much, but we have a lot of questions. We think we are smart, but we don't really have answers right now. And in the midst of it, we are going through our fatigue and waning motivation. And we have to look at the fact that in the global spectrum, unfortunately, economies, wars, and the GDPs towards arms are more of a priority than COVID-19. Ever since the Russia-Ukraine crisis came over, which was, I think, when a few of us had tears dropping in our eyes as we saw that healthcare focus caused by COVID has been deflected towards the arms race totally. So in the midst of this, let's get down to some brass tack points. Suresh, the clinical aspect. Dr. Raman talked of the fact that there's not much to distinguish. One, can you add to that if anything is there in the literature you have noticed? And at the same time, could you touch on some practical aspects like who would you investigate? How would you test at all? As he said that, first of all, the test, does the RAT work? And so on. So can you add something on those aspects for the clinicians to understand?
Yeah, thank you. Thanks for the wonderful opportunity. I first congratulate the API Karnataka chapter for giving this opportunity. Yeah, regarding these last 2 weeks, we have seen almost 50 to 100 cases of COVID in my practice. Most of the people, what they're complaining, similar to the COVID wave 1, people are complaining lack of taste, but not lack of smell. Lack of taste is quite common, people coming to the OPD settings. So that is one of the clinching points for me to suspect, to differentiate influenza from COVID, how to differentiate. Lack of taste is present there. And initial couple of cases, they vouched, they didn't have any contacts, any sick contacts in the family, they didn't travel, they didn't attend. So that make me to suspect initially when the family member says, in fact, one of the cases I saw, the patient is a CKD diagnosed 6 months back, and they told dialysis is needed. After that, the patient went into depression. She not even meet the family member. She stays in the room alone, not coming out of the room. But she presents with fever and shortness of breath that domain of time. We told them, like, because COVID, we are start seeing, we do the COVID testing. COVID came back positive. So this type of history initially made me to suspect there's no sick contact. I think one of the family members may be carrying the virus and they're transmitting to the people. That's what's happening now. So the OP setting, the clinching point is lack of taste. We have made it. Otherwise, some body pain and loose is also more common. Whatever cases we have seen so far, 50 to 100 cases, what I've seen. So people are complaining diarrhea, more of back pain and lack of taste. And similarly, people who are above the age of 60 with some comorbid conditions, couple of days of shortness of breath. They require 4 to 6 liters of oxygen or BiPAP oxygens, or sometimes the people are requiring HFNC also. Right now, also I just saw a case. They're requiring 4 liters of oxygens, only 2 to 3 days of fever. They called me and told COVID is came back positive right now. So people above the age of 60 with comorbids, we are seeing couple of days of oxygen. They're not going for a NIV or they're not going for ventilations, but they're requiring oxygen, particularly people above the age of 60 and comorbid conditions we are seeing now. So this is a differentiating point and looking at it. So whom to test? Right now, on an interesting video I saw in the social media there, it shows if young people, no comorbids, taken sufficient vaccination, 2 doses, or if they've taken 3 doses, also fine, and they're hale and healthy, no sick contacts or no elderly in the family, they just carry on by doing isolations alone. That's more important for me. Suppose people above the age of 60 with comorbid conditions, I'm planning to start, once the patient going to test it, I need to going to test for the patients. For example, I'm going to start on Nirmal Travel plus Retinol tablet. If I'm planning to start because of the comorbid or because of only 2 doses of vaccinations, I need to test. Suppose the patients in my hospital admitted for oxygen dependent, definitely I'm going to test for patients. So this is my protocol right now I'm following. The problem right now, influenza A, influenza B, RSV, other rhino intro is also going around the community. That's causing confusion to us, sir.
Dr. Suresh,
Interesting.
yeah, Dr. Suresh,
Yes, sir.
excellent inputs you have given for the patients. Do you find also that some diarrheal symptoms are coming up with GIT upset and other things?
Yes, sir. That's what I told. Back pain, diarrhea, lack of taste. These 3 things I'm seeing quite common.
But not to, but a smell loss is not coming.
The smellless people are retaining that. Taste is gone.
Yeah.
So, Suresh, the questions continue on the fact that now how do you test these people? Of course, whom to test will be an eternal controversy. And we can get into that, and I think the whole night will go by. But my question is, first of all, what's available out there? You have the RAT test, which are in every nook and cranny available, 50 to 100 rupees. And what is their efficacy with all the genomic stuff being discussed at length? And then the quintessential RT-PCR, which we have to hunt to find at this point, and the rapid test. What are you actually testing? Is the variant JN.1 or HV.1 actually going to be caught on the RAT? Do we have numbers, or do we go back to the quintessential last slide of Dr. Raman? We know little.
So actually, depending upon what setting you are practicing there, suppose you are practicing in a remote part, but the turnaround time, still the COVID PCR turnaround time is for most of the small centers, it is more than 36 hours or 48 hours. If you want to start the Paxlovid in Indian variant, we want to start little early. So if your turnaround time is longer, the rapid antigen test, you rightly pointed out, lot of brands, lot of cost is available. If it is positive, that is specific. If it is negative, it doesn't rule out COVID to me. Suppose my pre-test possibility is high, I'm testing with the COVID antigen test. If it came back positive, it makes my diagnosis confirmed. Suppose the rapid antigen test is negative, my pre-test possibility is high, I still go for the PCR test, whatever turnaround time. So gold standard is still PCR. But right now, commercially, for example, the hospitals, what you and I practices, the multiplex PCR is available right now. That's why we are picking up RSV, Rhino, Entero, along with influenza A and influenza B. But the cost is $15,000. That's called multiplex PCR for RV panel. If the patient is in hospitalized ICU setting, the patient is sick, I want to get the answer within 1 hour, I go for a respiratory viral panel. Suppose the patient comes to my OP and I want to start him on Nirmaltravir medicines immediately, that point of time I can ask, one panel is available, short panel, that is COVID, SARS-CoV-2, along with influenza, along with RSV. They recently launched three viruses are there, turnaround time is 1 hour. If I'm going to start Nirmaltravir Ritonavir for the patients in OP, then I need to do this test. If I just want to prevent the transmissions in the community or prevent the transmissions in the home, rapid test is fine for me there. Because I'm not going to start, I do the rapid test. If rapid test is positive, the infectious is very high. If the rapid test is negative, I told them, you can isolate, you can put a mask, my pre-test possibility is a bit high. So this is how I do that. If I want to treat means, I need to do the PCR. The PCR, either alone PCR or combinations of PCR. If I'm going to just isolate the patients, I have to do the rapid test. If I want in the ICU, I need to do a panel of tests to find out what is going in the community, because all three is overlapping now.
Dr. Gilada, let's talk a few parts of those isolation things which you mentioned. Now, Karnataka in its wisdom has decided to have 7 days isolation for everybody, more as a statement and as a order rather than, I'm not sure what the implementation is. Dr. Raman mentioned 5 days or the fever part. In the same time, I think tongue-in-cheek, he mentions anyway who's going to listen to us. What's your take on this? And then anyway, you with your background of HIV and so on, where do you think with these patients are headed? Do you think there's more of a risk for them? Is JN that these alphabets going to cause any more problems? A few mixed bag of questions, but I thought this would be a good thing for you to take up.
Thank you very much. Basically, if you look at little bit background check, every newspaper says, do not panic, but be cautious. My take is that do not panic, do not be cautious. Nothing is required. Karnataka government gave a whole list of hospital beds which are reserved. How many oxygens are reserved? How many ambulances are reserved? What will happen by that way is that other people requiring, they will not be provided bed or hospital or oxygen. And that's what happened during the entire 2 years period of the COVID, thick of COVID, that there was a lot of collateral damage caused. With collateral damage, what happens is you become COVID-centric. Currently, as has been also spoken by Ganga and Suresh, that we have H3N2, H1N1, RSV, and COVID. And other two are more prevalent than COVID. So in this sense, we should have a common program, ILI kind of program, rather than a vertical COVID program. That is number one. Number two, in a jocular form, JN.1 is a Jawaharlal Nehru.1 virus. And they are attacking Gujarat. Gujarat is the highest number of cases. So there are always some kind of anecdotes coming here and there. But we need to go by trajectory. It is the Omicron subvariant. And what happened with Omicron is that Omicron BA.1 was initially from South Africa and spread to Europe. But India never got Omicron BA.1. It got BA.2. And somehow BA.2 has given us immunity from BA.3, 4, 5 and descendants of BA.2. And that's the reason I have been calling for the last 1.5 years, 2 years, that Omicron is a variant of support for India. Only after Omicron came, everything opened up. Schools, colleges, economy, tourism, socialization, marriage, everything opened up. So a lot of people got infected, but trajectory was that people were not requiring oxygen, not requiring bed, not requiring ventilator, not requiring ICU, and death rate was very low. Now, when you talk about death and you say people with comorbidities or people with 60 plus population, even without any infection, you take any 10 years slab between 50 to 60, 60 to 70, 70 to 80, more deaths will be in 80 to 90, less death will be between 70 to 80, further less will be between 60 to 70. So comorbidities people and elderly population, it is like anything coming, the last straw on camel's back. What we need to see whether COVID is a coincidental finding or it is a cause of death or cause of hospitalization in that person. Currently, everything is vague, and whatever planning is going on, we should have a pandemic preparedness rather than only COVID preparedness. We are well prepared. We have well vaccinated population. We may, if we require vaccine at all, if at all, we need to pre-order the vaccine to the companies. Companies are not going to produce a lot of doses of vaccine, and that's what we failed initially. So we should not fail now. So currently, what we see that JN.1 is a very, very mild version of the virus. Whatever newer versions are coming, they are milder and milder and milder. It has been prevalent in 40 countries already. It has not caused a lot of deaths, not of hospitalization. So we should go by that, and it is not going to create any havoc. There are people like Sutra model, which is a COVID projection council of India or something. They call themselves and they given a date of 21st June 2022 as a fourth wave going to come. Where is that fourth wave? Never happened. So we should not go by this kind of non-medical, non-scientific people hogging headlines and talking about all the things. And there is no need of any COVID bulletin. There is no need of any kind of, you talk about COVID appropriate behavior. Only thing which we can see is masking. Social distancing in a country like India not possible. Personal hygiene is your personal question. You don't know whether the person has used sanitizer or not. So only masking remains. And only we should effectively talk about masking. Lastly, our health science communication. Whatever is happening in genomic lab, why it should go to newspaper? And that's what is happening for last 3 years, 4 years, 10 years. So unnecessarily we involve people who should not be. It is only scientific community's issue, It is variant of interest. It is not variant of concern. So variant of interest may be variant of concern for us, scientific community, but not for common people. So in health science communication, that is another important thing. You don't talk about numbers, you give denominators. Tomorrow it will be 800 positive, but how many people were tested? The testing are more than yesterday, the numbers will be positive more. So if don't even go by numbers, and people, countries number one in population will be always having number one, number two, number three problems. So talk about infection per million population or per lakh population. And when we talk about that, even during the thick of the epidemic, India was at 166 country, not first or second. So I think we need to look at a lot of issues when we discuss COVID or any such kind of pandemic or mixed infection coming.
So isolate or not isolate?
No, not required. Only
Okay.
for 3-4 days. See, by the time you realize, already 3-4 days are over. You are in a diagnostic dilemma. You don't know whether it is because when influenza A and B are more common, RSV more common, it is like 9 versus 1. In that situation, what are you going to do? 3-4 days are already over. You can tell people, if you have an elderly person at home, either ask them to use mask or you use mask when you are going and socializing and coming back home. That's it.
I think Dr. Gilada is saying mask the public and maybe in some way mask the media also so that we don't go nuts over this. Now, coming Dr. Singh, let's lay the investigation part to rest. What about all these fancy blood tests and the CT scan spectrum and all? What's your take on that? Should we be even looking at those things as were done before, or you know what, once and for all, say forget about all these ferritins and IL-6? By the way, I can't even get IL-6 easily. It takes 2 days now. Ferritin, of course, is easier. CT scan is still available. What's your take on these tests for as a general guideline for all of us to think about?
Thank you, Dr. Mehta. I think Dr. Ishwar has given a so beautiful input. And this is very practical for our country. Dr. Raman also told that you can say about masking, you can say about the isolation, and you can say about many things. But the public is not going to follow at present. What is the scenario is that? As far as the symptoms has been told about the cough, fever, or sore throat, or dry cough persisting over 10 days. Suppose in my clinic today, I saw 4 or 5 cases. They came at 7th or 8th day, doctor, my cough is not going, but I had a bad sore throat, some running nose, some fever, 1-day fever. And at this moment, I don't find that any need of doing much investigations. So maximum what you can do, you can go for a complete blood count or CRP. That will be sufficient for us. But only in the comorbid, if the comorbidity is concerning, then in that case you can go for further test. But I don't think there is any need of doing CT scan at present at all. So already Dr. Iswar has given us such a beautiful idea that this is a various only for concern. This is not going to do very harm so far that the data is coming up. Even from the Delhi today, some cases have been reported, but these are all mild cases. As far as death is concerned, again, it will be very difficult to say that this JN1 is causing the death. So many comorbidities are there, some influenza viruses are there, and so many things are there. So at present, I will only advise that you go for a simple checkup, physical checkup, take a good history, and there is no need of going for all those high-sounded tests. So this will be a very practical aspect. And what I predict that you will see that after 1 or 2 weeks, no news will be coming about this virus at all. This is my prediction. Thank you.
Okay, excellent points. I think we have another 5 minutes more. So let me ask the question, which is a burning question for everybody. Dr. Raman, and I can take more people's opinion on this. Everybody wants to know, should healthcare providers vaccinate or no? The second question I'll put in the mix is I'm totally playing the devil's advocate. mRNA vaccines we have in our country, hardly any data. And we debated this in the Apollo internal system before vaccine recommendations. mRNA vaccines associated with complications are plenty. mRNA vaccines not available in large quantities, so where is equitable justice? And lastly, when Omicron itself was the best vaccine which circulated through the country, and we have so much of this, then, why, if at all, vaccinate unless you really, really define the high-risk population? We've never really defined this high-risk population well. You guys look like such lovely, great above 60, some of you. Should you be vaccinating you when you don't look like you have comorbidities and you may have more complications when you already have good immunity? And last but not the least, we have still not figured out how to figure out this vaccine immunity. We need a measuring parameter. If we need it, then we can revaccinate accordingly. So a lot of points as well as things in the mix, but what should healthcare providers vaccinate, and should vaccination guidelines be given out at all, or they just more protective when it comes to all these points? Dr. Raman? Is he still
Am
there?
I audible? Am I
Yeah,
audible?
sir. Yes, sir.
very.
Now, you
Very
asked a
much, sir.
difficult question, sir. No, but I will try to answer the best possible way I can, even painting scenario of uncertainty while we take these kinds of decisions. No, I think it's a personal choice. No, when it comes to healthcare workers taking vaccine, no, there will be two factors that we have to think about. We are all at least older people who have less life looking ahead, where perhaps we may not worry as much about post-COVID syndromes because we think we are doing our best, we are doing well, our expectations from life are minimal. But if you actually read the literature more and more, you will find that those who are younger, even they are known to have low sperm count as a manifestation of COVID, even if it comes from variants. It is known, perhaps now there are reflections which tend to suggest that the risk of oncologic manifestations increases because this particular COVID virus can influence the same. Now, are we in a position where we can say this happens? Certainly, we don't know. But if I want to prevent, would a physician take a decision? Physicians is the worst community. Do we take influenza vaccine as often? You will find our percentages are low, where we have huge data that is available there. So to me, leave it to the personal choice. Now, the second issue that you brought about was about mRNA vaccine. They have actually got better details now. Now, they never thought that the Omicron variant based vaccine could be used for public health purposes because they started late. It was difficult to establish production facility for mRNA. It is the only facility that we have as of now. So they actually ended up with positive outcomes late when the COVID outbreak was actually on a complete decline. Now, do we think that this mRNA vaccine is going to be radically different? I used to have all kinds of doubts because our Omicron vaccine is based on not non-replicating mRNA sequences the way we see in Pfizer or Moderna. But here, they have something where there could be a self-propagation which will last for about 10 days time. I have looked at their data. I do not think the data tends to suggest that my earlier cause of concern may be valid. No, but each one of us is empowered to look at that particular data. They can ask for the data and take decisions for themselves. Now, the third thing which I say, what did I find during all the discussions? No, this is not to hurt anybody. We as healthcare providers love to believe that I can take decisions for my population. Some statements that Omicron saved us. Do we know what would be the damage to different organs over a period of time? We are least worried because we tend to handle everything on case-to-case basis and we look at immediate outcome. Whether the person will not die, whether the person will not be hospitalized, but even if he survives, what is going to happen, we do not know. So there is a huge amount of uncertainty. And as we say, health is about more of prevention rather than treatments. Treatment is about reducing the worst outcomes that are likely to happen. So to me, the decisions on how the vaccination schedules will have to be tweaked, we will learn over a period of time. That dilemma will continue to exist. So I respect your questions. They are very difficult to answer because I think most of us are ignorant. But at the same time, we have to think. I tend to get worried about children. ACE2 receptors are present everywhere. You cannot prevent transmission in children. We have no idea how they would become older and with which morbidities and which diseases. I think at present the prudent policy should be that keep the research a strong way, think to avoid infection in a strong way. Those who come to you who are more likely to die, whether because they are elderly or at-risk individuals, we have to prevent them. That's a short-term gain that we will have. In the longer run, we are yet to find a good solution. Over, sir.
Yeah, thank you so much, Dr. Raman. I think in the interest of time, we have to truncate.
Can I interrupt? Yeah.
Yeah, Suresh, come in.
Yeah, regarding this vaccination, because this is a huge challenge and everybody is asking whether can I take the vaccinations or not. So I was going through the thing. Yesterday, one preprint from preprint is published in bioRxiv there. It showed the Omicron specific or monovalent specific vaccinations prevent 60% of hospitalizations and 60% of emergency department visits. One. Second thing, as a healthcare worker, why I need to take vaccinations during the time of Omicron, during the time of Delta. As a healthcare worker, we need to be available for the patients. That depends upon the intensity of the wave. So we need to wait. We are in the early part of wave right now. So we need to wait a little bit more time, whether the workforce is going to affect or not. That decides the healthcare workers to take vaccinations. But according to the preprint, what it shows, the previous vaccination, that is wild type specific vaccinations like Covaxin or Covishield, it is not going to give any additional benefit for you. The Omicron specific vaccination is going to give a benefit for you, prevent the hospitalizations and prevent the emergency department visit. That's what the preprint shows. 60% reduction is happening there. And third thing, what is the good news is, Eric Topol clearly put in his paper saying that after this JN.1, there is no variant is waiting for some more time. There is no variant is waiting. So once you cross this variant, I think the good news is next 6 months to 9 months, something should emerge. Till that time, we got space. So we got a space. So we need to get away with this variant so that there is a space. There is no variant is waiting to come emerge or something there. That's a good news there. So based upon these things, if you are a healthcare worker, if the wave is going to be much higher, better to take a vaccinations. Ideally, Omicron specific vaccinations. That's what the data is available right now. Otherwise, don't take Covishield and Covaxin at this point of time. It is not going to give a good benefit for you. It increases other things only there. So that's my take on it.
Excellent. I think it's
सर एक 2 मिनट लेता हूँ सर. What sir said, Dr. Suresh I agree with him completely. But at the same time, I do not agree with Eric Topal's comment. No, you will always find the development of variants will continue to exist and they are going to surprise. Now, how you measure that? No, and a variant that increases hospitalization or impacts death, or a variant that can evade your immune system and infect you, it depends on what outcome am I looking at. Where is the answer? The answer actually has to come from a pan-corona vaccine, which has to be developed at the fastest. There are efforts that are even ongoing across the world. There are 10 different kinds of vaccine approaches that are being developed for pan-corona, whichever coronavirus tends to come. Let us hope that will be successful. And we should also hope that one of the places where it has been invested in India in biological events, with the government of India's this thing for development of pan-corona vaccine, perhaps become successful. But I fully agree with him that it is quite possible that these vaccines may be taken by general public or elderly is likely to be a dream. But the bigger possibility is healthcare workers will have to take it in order to protect them over a period of time. But that's a reflection as to how people think. Do they think I have very little life to look forward to for long COVID manifestations, or I need to be useful for the society? It's a choice that we will have to make. Things will happen, sir. We have to give time for people to absorb and react. Though we are poor reactors as healthcare providers for H1N1 also. So far, our past is bleak when it comes to vaccination.
Thank you, sir. As a moderator's tough task, I have to conclude a lovely discussion. I think we started off with ignorance. We went up to a lot of information through Dr. Raman. We wound up with concerns, and Suresh tried to put a positive spin onto it in the end. I don't think we have all the answers, but there's plenty of areas of work, and indeed the global community is working hard. On the vaccination front, it stays an individual choice with paucity of vaccines, paucity of data, lots of concern, and two major inflection points. Do you want to take the vaccine to save hospitalization, or do you want to save the vaccine to save long COVID? Long COVID has rearing its head in a way which is unfathomable. Recently, there was a gentleman called Dr. Narayan Naidu, who heads the global mission, who talked of the HMRD, human metabolic reprogramming and dysregulation, part of which is this fertility and the children part, which Dr. Raman mentioned. So I don't think we have answers. We know that this virus will go on. Eric Topal notwithstanding, whether it's a Diwali, Dashera, or a Christmas virus, time will tell. And this is something we have to deal with and keep working fervently in the background to get answers. So with this brief end summary, I think we conclude this session. We hope that we've been able to answer a lot of the questions, though we will never be able to take the vast array of queries which are there. I hand over to Dr. Sangram Biradar and thank my august panel who actually had so many thoughts which have left me with questions for 5 more webinars. And we hope that this is the beginning of a progressive learning experience as this wave unfolds, no doubt for the next month or two, as we run amok in this new year. So Merry Christmas and Happy New Year, and back to Dr. Sangram Biradar. Thank you.
Thank you. Thank you for your wonderful moderation, sir. Before we close, we will have a take-home message from each one of you. Dr. Murali Mohan, sir, anything you want to comment?
Nothing at all, except, we have to keep our eyes open, ears open, and be very careful. We are seeing a combination of flu and COVID, some of them with very bad outcomes. And I think the panelists have already clearly said what we need to do to be aware and take preventive action. But only time will tell. So let's wait and see.
Yeah, thank you. Dr. Gilada, your take home message.
I think at this stage, we don't have to panic. We don't have to be overcautious. This issue remains with medical community, scientific community, and the key ministry in government. Beyond that, it is nothing to be required for the common people. We should harp on the century-old technology of wastewater surveillance, because that is one of the cheapest way to foresee in next 10, 20 days what is going to happen, and continue to have a genome sequencing. Thank you.
Thank you, Dr. Singh.
I think with variant of concern and variant of interest, so maybe this virus will remain as a variant of interest only at present, but already Dr. Sangram, you have taken a lead in educating us about this thing. But I think the most important message which comes today is Dr. Raman told about the prevention, the appropriate COVID behavior. But in that scenario, I find that some new research has come up that doing a regular exercise keeps your immunity. Very important research with the COVID also has come up that doing a regular exercise, you can keep away all these virus scenarios. So I think this keep your immunity, boost your immunity. This is the best thing which we can do. Even about masking, I am not sure people are going to have use of mask at present.
Yeah, thank you. Dr. Suresh Kumar.
Whether you take the COVID booster or not, what is needed is influenza vaccine. Right now, influenza is also rampant, and influenza vaccination demonstrated good efficacy. Take at least, because we need to take every winter, that's September we is supposed to take. So those who have not taken the vaccination, please take influenza. That taken care of the 50% of your problems.
Yeah, thank you. Finally, Dr. Raman, your take home points.
सर मैं तो सारे टेक होम पॉइंट्स मेरे बोल दिया लेकिन if I was to summarize, people should not panic, those who are part of the larger community, but doctors need to be vigilant. Perhaps one learning lesson that COVID is going to teach us is doctors will have to not only protect ourselves very strongly against highly transmissible respiratory infections per se, to provide their services to others who are required to save their lives, no? And there may be a sea of change that you will see over a period of time, that there could be something like doctors' vaccination protocol, doctors' prevention protocol, because we are going to get exposed. And these kinds of organisms are going to keep on coming. But let us keep our hope alive that we will be able to stop this particular coronaviruses per se through pan-corona vaccine that could come. Hope for the best, but don't speak about our concerns that we have, not only about our own health, but the implications for post-COVID in public, because that could create a major scare.
Yeah, thank you, thank you. So now I request Dr. Vishwanath, our secretary, to propose a vote of thanks before we leave. Kindly unmute Vishwanath.
Sir. Good evening, sir, and always an informative session from Dr. Raman, sir. It's a pleasure because it gives the information so crisp and take-home messages. As I said, all his slides were take-home message. I do hope that the beta follows the father and becomes benign. I know, as you said initially, not the Savai beta. And of course, wonderful moderation from Dr. Ravindra Mehta, Dr. Suresh, sir, regarding vaccines. Dr. Ishwar, yes, underlying the importance of not to panic. And I think overall regarding influenza vaccine, yes, I think that's a very important take-home message for all of us. In fact, in our hospital, we have started that give influenza vaccine. Also thank my chairman, Dr. Murli Mohan, and as usual, Dr. Sangram. Wonderful session. I think we had a very huge attendance today. So, thank you all. Happy New Year.
Thank you, sir. Thank you, one and all. Thank you. Thanks for sparing your valuable time.
Happy New Year to all of you. Thank you. See you next year.
See you next.